30 seconds. That's how long it'll take you to watch this announcement. What if I told you that in just 30 seconds, you can help someone just like yourself to live again, to love, to play, to laugh? By joining the Armenian Bone Marrow Donor Registry, you're taking a huge step towards saving an Armenian life. Once you're registered, you'll be part of a vast network of donors who have already saved lives all over the world. But we still need your help. Only an Armenian donor can save a fellow Armenian, and it only takes 30 seconds.
Բարև ձեզ սիրելի հայրենակիցներ, ես դոկտոր Ֆրիդա Ջորդանն եմ, ողջացույցի դոնորների հիմնադրամի նախագահ։ Մենք տարիներ է, որ շատ մոտքից աշխատում ենք Լոս Անջելեսի Children's Hospital-ի հետ, որ կարծում եմ աշխարհի ամենահայտնի հիվանդանոցներից է երեխաների տարբեր հիվանդությունների բուժման գծով, բայց մենք մոտից աշխատում ենք իրենց փոխպատվացման Bone Marrow Transplant Unit-ի բաժնի հետ, որի ղեկավարն է դոկտոր Նինա Kapoor-ը, որ մենք շատ ուրախ ենք, որ այսօր ինքը մեր հյուրն է եւ մենք կարող ենք խոսենք տարբեր հիվանդանոցում եղած տարբեր մոտեցումների մասին, որ իրենք որդեգրում են երեխաներին բուժման գծով։ Ես իմ հարցազրույցս պետք է ունենամ անգլերենով եւ հույսով որ դու կարողանաք շատ մոտքից հետևեք։ Welcome, Dr. Kapoor. I'm so happy that you made your time to come to this interview. I know that how busy and you are and how precious your time is in treating your patients. I want us to start by going through, say we have a patient, a patient with leukemia or other blood-related diseases, and they come to your hospital, to your department, and how do you deal with these patients?
Parif, and thank you very much for inviting me here today. Yes, I can give you the details of it. So when a child is presenting with one of the blood diseases, whether it's in a leukemia, it is in a sickle cell anemia, thalassemia, or immune deficiency diseases, the physicians who are initially taking care of these children will give them the frontline treatment. And that may be for a leukemia patient, may be chemotherapy.
Yes.
Depending upon what type of disease they have, if there's a high-risk disease, then maybe in first remission. But otherwise, in some standard risk disease where they feel the child can be cured just with the chemotherapy, they'll continue to give chemotherapy. However, if patient have a relapse of the disease in spite of getting good chemotherapy, at that time they might refer the patient to us to do the transplantation. Obviously, to proceed with the transplantation, we still have to achieve initially the remission. So yes. That's an important thing to recognize, that yes, patient could relapse. At that time, they could be requiring more intensive treatment. And then at that time, we start our process. The process is to find a donor. We can't do the transplant without a donor as such. So in that case, first attempt will be to look in the family and see if any one of the sibling is a match with the child.
Yes.
So there is 1 in 4 chance that any one sibling who is the product of the same 2 parents would be a match with the child. But then 75% chances that nobody might be a match within the family.
Absolutely.
In that setting, the question comes of what do we do, because it's only 30% who will find the donor within family, that for others we have to look outside the family. And that's where the registries come in play.
That's why we come in.
Exactly. So
yes.
People at random who are from the similar community and some ancestry, there is one major thing to recognize, that we share some genetic material being descendant of the same community.
Yes.
As we are looking outside that particular community, they will have different genetic makeup. So our chances of finding a donor from within the community is higher compared to other. And then it is also issue to recognize there's some genetic makeup which we're talking about doing the HLA typing. This is the tissue typing.
Yes.
Okay. It is some are very common type, very conserved HLA typing. So for some patient, we could find 100 donor.
Yes.
Okay.
Yes.
But then others, it may be their genetic makeup is so dispersed, they're so different that we may not find a donor, and then we have to keep looking for them. And there may be a rare chance that we'll find a donor for those. So we have a full spectrum of it, with how good a chance there is to find a donor for one, and how rare is the chance to find for another. And that's where the number game really comes in play, that more donors you have, better chance there will be for us to look for that rare donor patient.
So it's very important for any registry to increase their number of donors, especially if it's a ethnic specific registry.
Exactly.
Okay, so I just want to this be also educational for our public to hear. So when you decide, your transplant center decides to find a donor for your patient, then you send us an official search request.
Right.
And that means that it is a form that has got all the information about the patient as well as his tissue type.
Exactly.
And then we officially are able to send you the information that we have in our registry.
So you will match our patient with your registry and say if any one donor, volunteer donor which you have in your registry is a match or not.
Yes.
Okay.
So in other words, because sometimes the Armenian patients, when they refer to us, they want us to ask the transplant center to send us a search request, which should be the other way around.
Right.
And that is not the right course to go.
So your physician who's been taking care of
Yes.
the child will be the first person who will say it. It's just like the oncologist will be sending patient to us.
Yes.
We are evaluating and finding whether it's an appropriate patient to go for transplantation or not.
Absolutely.
That will be the first step.
Yes.
Second step is that once we determine that yes, it's the right disease status, and the clinical status of the child, that's very important too. Then we try to find a donor through the registry. Means first attempt was within the family, and if we didn't find a donor in the family, then it will be in the registry. Once we recognize that yes, if you send the information we sent to you, that this is my child whose tissue typing is this particular XYZ, does anybody in your registry match with this person or not? You will say, yes, God willing, yes, we did find somebody who's a match. The second step is to do the confirmation.
Yes.
That will be, then we will be requesting that the donor who was in the registry, we have the second test done and confirm it that yes, and that will be detailed DNA typing.
Yes, more and high
resolution to be
yes.
sure that that person really is a match.
Yes.
Because the chances we are looking outside the family, there will be many reason to say that some may be conserved HLA typing, but other may be very variable. So we have to be sure it's a perfect match.
Yeah.
Yes, we are able to accept when we are doing the tissue matching, which is 10 different parts of the genetic material which we are looking at. Are they match in all those various loci? But even 9 out of 10 match is quite acceptable in those cases.
Especially for children.
Right.
Yes.
So it's
yes.
And so in that setting, once we identify the donor, then there are two things that are happening simultaneously. One is we are re-evaluating the child to be sure that their physical condition is good enough to go through the procedure of transplantation.
In other words, if even the registry finds you 100% match, there is absolutely no guarantee that that match is going to be translated into a transplant.
Right.
Yes.
For two reasons.
Yes.
One reason is towards the patient who needs a transplant. We have to make sure that they are able to go through the procedure of transplantation. So we do their organ function assessment, heart, lung, kidney, all get evaluated. At the same time, the donor is also evaluated.
Absolutely.
Okay, to be sure they're in good health and they're able to donate.
Yes.
That's another important thing. So both things get evaluated simultaneously. If both ends seems to be appropriate, yes, then we can proceed with the procedure of transplantation.
Yeah, and sometimes you are also find 100% match, but you put a hold on everything because probably your patient also goes into remission, and you don't need to go ahead with the transplant.
So sometimes that may be the situation where suddenly, most of the time, if the patient initially get referred because they had a high-risk disease, yes, the remission part, remember we did say that patient has to achieve a remission. That would be our best chance to really, so the procedure of transplantation, if I may say,
yes,
the whole thing is that with the initial chemotherapy, we debulk the disease. But we can never be sure that the seed cell for the leukemia is still in the body. In reality, transplantation actually goes after that minimal residual disease. It works best when we are taking a patient who is in remission and who has minimum residual disease, that we can go after that with the transplantation, wipe off that seed of the leukemia. That's really is the objective. Doing a transplant in relapse is very poor outcome. Some people have refractory disease, never go into remission.
Yes.
Those patients will have very poor result. They have less than 10% chance to have a successful outcome.
You hardly perform that.
Right,
yes.
right.
Yes.
So yes, the remission is important, but there could be many other reasons why a patient should not have a transplant. Whether patient's own clinical condition does not dictate it, or suddenly they may have, for one or another reason, physician may decide that that's not the route we should be taking, and we can wait in those cases and see how their course is with the chemotherapy, and may come for transplantation only if the disease relapse.
Yes,
that's not only.
Yes.
But even at that time, they have to go back into remission before they will be acceptable for transplantation.
Yeah. And usually the communication between the transplant center and the registry stops after you get the search request from the registry, the search report. And then if you are happy, you stop, or you want to further testing, you just pick up a donor, then you further test and you stop.
Right.
And that's it. And there is because there is this gray area which they think that we need to keep pushing the transplant center for our donor to go through, and we keep saying to the patient family that this is not our place to do it. Right. The transplant doctor, the transplant center exactly knows when they want it to be done, right, and what is the course of action to be taken.
Right.
They can completely ignore us also, because there can be a case, sure, where we have a donor in our registry, which is obviously Armenian background, and there is a donor in National Marrow Donor Program, which we don't know the background, and both are 100% match. But it's up to the transplant center to decide which one, right, to take.
So there are a couple other criteria which,
yes,
we do take in account selecting a donor. Age of the donor. Yes,
yes,
we like to have younger donor. That's not something which biologically we feel is a better donor for us rather than older donor. We don't say elderly. Also, donors' exposure to various viruses. We do the assessment, and if somebody, let's say we have a CMV negative, yes, recipient, then we would prefer to have CMV negative donor.
Yes.
Let's say blood group.
Yes.
It's not absolutely mandatory that they should be blood group matched, but we prefer that they are blood group matched because some of the other complications are more common if we do have blood group mismatch. But it's not an absolute contraindication for us to accept a blood group mismatch. But all those various points come in play for us to make a selection of the donor that whom we would like to have a donor as far as selection of the donor procedure is concerned. And then everybody needs to recognize that we do have tissue typing where it's a major histocompatibility typing. So we are only looking at the major component. We are not, there are minor components which are minor histocompatibility antigens are scattered all over our genetic material. We are not doing those testing. And yes, we will have a better chance, just like we have a better chance within the family to have the minor antigen being matched with the patient and donor.
Yes.
Similarly, it will be better chance for having a donor coming from similar community than outside the community. So that definitely is an advantage of having a donor from within your community, because hopefully there's a more sharing of these genetic material within that community than is going to be outside.
Yeah, I think that's a very good point. Now, Dr. Kapoor, after you found a donor and you have decided on the transplant, then your hospital goes through a very extensive consent meetings with the family.
Right.
I think we would like to hear that because it's very educational.
Yes, and so I would like to say that everybody recognizes that transplantation has a potential of curing the disease.
I love the word potential.
That's a potential. Nobody can give you 100% guarantee. No physician will sit down here and say, oh, I can guarantee you this will cure your disease. But it is a potential to cure the disease. And so we go through the process. We know that family is sitting here with the great hope that this is a treatment procedure which is going to help us in getting that child better. But we sit down that time, and I'm surprised sometimes that how families listen to us and still come back for transplantation, because at that time we have to tell them that what might go wrong in the procedure of transplantation. Transplantation procedure is a radical treatment. It's where we are wiping out their whole blood forming system, their immune system, and with the intensive lethal doses of chemotherapy and radiation therapy. So it's not a procedure which can be taken lightly, and we have to be sure that family is recognizing that it's a radical procedure. Yes, we hope that will cure the disease, but there are potential complications which can happen, and we would not take a child for the procedure of transplantation without family knowing the details of all potential complications which might happen. We hope those don't happen, but they all need to be aware of that there's a risk for it. And so we go through this massive process where we review all these potential risks in the verbal communication as well as in writing. So they are fully aware of that there's a risk that we could lose the child in that very short period of time of undertaking a procedure if any one of those things can go wrong, which could be infection, which could be organ failure,
secondary
complication.
Yes.
So that's a very important thing for people to recognize. Of course, over the years, we have made major attempts to minimize those side effects. And yes, it's much safer now than it was 20 years ago. We have better resources to support our children, but these complications can still happen. Absolutely. So we have to make sure that families are aware of that they are taking, yes, there's a very good chance that disease will be cured with this particular procedure, but there's a little risk which we are taking, and we cannot predict it up front if any child will have that risk.
I think it is the toughest portion of everything, that to explain it, and then the expectations are very high and they can be disappointing or they can be very jubilating, you know, at the end of the day. But your hospital has got such a good reputation, and we are so honored that throughout the years we have been working with one of the world's best transplant centers for children. And both yourself and Dr. Siegel, at the beginning, we were working so closely, and you kind of mentor us, Armenian Bone Marrow Donor Registry, to start the registry, to start the harvesting center, and even we brought our physicians to your hospital for training.
And we were very honored to really be part of that process. It's the knowledge which we gained over the years that we are able to share that with our colleagues and make it happen for all the children anywhere in the world. It's a pleasure for us. It's a great honor for us that you have given us that opportunity to become a part of this whole process.
We are so humbled. I mean, everywhere I go in the world, I talk about Children's Hospital because you're a part of my presentation, and I'm saying this is happening in America, where we have such an hospital which is willing to share all their protocols, all their know-hows, how to do cryopreservation, how to do harvesting, and any other issues that we can face to deal with our transplant program in Armenia. We are so grateful, Dr. Kapoor. You don't know how grateful we are.
And I'm looking forward to that trip which you're going to be making this.
And now we're going to the other good phase, that this October 3 to 4 we have the second European Federation of Immunogenetics workshop in Armenia, and you graciously agreed to come and give the two very main lectures on leukemia and cryopreservation.
It's really my honor that you have felt that I'm worthy of this this process, and I feel that yes, what we know here over the years, we have gone through the pitfall. We know what could go wrong, how we can improve those things. That sharing all that information is very important for all of us in the field of medicine. What we are doing today, we learn from others, and we are just sharing that information. Yes, so that makes me humble.
Absolutely, medicine doesn't have any borders.
No.
And that is the real case with the attitude that your doctors have shown us, yourself and Dr. Siegel, and I really want to thank all your administration for facilitating all this. Unfortunately, we don't have still the transplant center in Armenia, but they're building one, and hopefully within 2 or 3 days that will be a reality. But I'm sure that when you go to Armenia and you give your lecture, a lot of physicians will surround you and want to take all your knowledge that you have in this field to share with their patients.
And we'll be available for them anytime. This is something that the process doesn't stop at one stop.
I know.
It's an ongoing process, and we'll be
I know.
more
and we
than
discussed
glad.
the telemedicine.
Right.
Yeah, still it's on our agenda, but we want to have the right place, the right atmosphere to start it when the transplant center is done. So we'll have more patients to treat, and that would be the first thing that we can implement. And tell us more about your telemedicine product that you have.
So essentially, we are able to. Telemedicine is really that I'm sitting here. It could have been an auditorium where the hundreds of doctors are sitting, and we could be giving that talk. Here with telemedicine, similar things can be mimicked. That I'm sitting here, and in a big screen, they will have all these participants who are sitting there. It's interactive.
Yes.
So I'm giving my talk. They have questions. They will be asking in the real time. Just like if they were face-to-face with me. Yes, they are face-to-face with me, but on the screen. And we can provide that sort of interactive education part to anybody, anywhere in the world who has. All they need to be sure that they have the similar equipment which will be able to transmit the audio as well as visual part. So that's a part which I know you are already in the process of establishing over there.
Absolutely.
And it will be a pleasure that I love to teach, and I'm sure there are many other people in our group who love to do that. And it will be something that, yes, in today's day and age, we should be able to communicate in that fashion so that we really stay up to date. At present time, we are even doing for some of the cases that your patient is being seen in the place like we had with Panama. There's a physician who is seeing the case, letting us know, visually see what the findings are, doing the examination, communicating that to us, and we are assisting them to really with the investigation and with the diagnosis and how to treat it.
I think it's a dream of many patients in Armenia to have a consultation with a physician like yourself sitting at the Children's Hospital. And I think our goal in future should be to make that dream true, because with the very little effort, you can have expert opinion on any child's prognosis or diagnosis, I would say.
That's very important. And then how best to treat that particular child rather than, and the best thing is that you are training the physicians there. You are making them as part of that process, so they know, they have doing that firsthand, and before they know that second patient who comes along, they have already done it with one patient. So to me, that's more productive than just saying one patient coming here for treatment, and yes, we take care of that, but the knowledge does not get imparted to the people who actually seeing the bigger population.
Absolutely.
So that's a very important part.
And they don't have the resources to travel to America. So it's very important to make the infrastructure
there.
Build local infrastructure, yes. So as a registry, see, this is where people get confused, because we are not doing only the registry work. Because the registry work is just maintaining the registry, adding donors on the registry, but Unfortunately, due to special circumstances of Armenia, we have started having harvesting center, cryopreservation, and now we're thinking of helping with this telemedicine and everything. That's why people get confused of our role with the hospital.
So those are two distinct services you're providing.
Yeah.
Registry is very unique thing, which is, and obviously even here, it's a volunteer process that people are volunteering and they want to be in that registry. And larger the number is going to be, better chance there will be to find a donor for a given patient. As I said, yes, for some patient, you probably could find even if you had only 100 members in there. But when it start becoming a combination of genetic material, which is not that common, for them, we need to have larger number of volunteer, so that that increases the chance. So that's a different activity. Us to find a donor and making all that effort that yes, all those donors are being maintained. That's another thing, is that yes, I may have this donor drive for one given patient, but those donor needs to be maintained for not only for that patient, but all the patients who might need the transplant. It's a very important thing, and that is the activity of the registry. Yes. And then obviously the treatment part is a separate activity, and what you have done already in Armenia, helping us to train those people. Obviously, that was your effort to bring those physicians here and train them that how to cryopreserve. I mean, that was for autologous transplant. That's their own marrow being given back to them
which is the
after
first
high-dose chemotherapy
stage of transplant.
Right.
Yeah.
So yes, the first one, but there's a specialized thing which we would not need for allogeneic transplant. We don't need to freeze that marrow because you are taking fresh marrow and giving it to the patient. Whereas for autologous, it's your own marrow. You are taking it out because marrow is not disease. It's the other part which has a cancer or other disease. So you can take this marrow, you can freeze it, and I have used actually right now about 18-year-old product, which was saved.
Really? Oh.
Yes, so which was saved, and
after
we were able
18
to
years.
18 years. Yeah, so you can so it's in the liquid nitrogen, so you can keep it for extended period of time.
Yeah.
Means we haven't done to infinity, but but I would say that if there's it's maintained, yes, it probably would be very well preserved. Question really is, are you able to maintain it constantly? Means yes, your freezer should be working all the time. The quality management, all that stuff needs to be looked at. So yes, you can keep that, and that is the product that after intensive treatment, when your blood cell count has gone down and sometime even completely destroyed, you can rescue the body by giving your own cells back. So those are the treatment for a lot of type of solid tumor. You know, whether it's in a question of some brain tumor or the neuroblastoma. Those are very serious illnesses, but you can do the transplant for that type. With autologous, their own cells can be given back to them.
Unfortunately, we are running out of time, but we're going to have other sessions, especially after you come back from Armenia. And I'm sure you want to have to say another word in Armenia, because I'm going to say thank you so much for coming, Dr. Kapoor. Thank you for all your help and support. And in response, you're going to say,
Shnor Akalutun.
Yes, that's it.
Okay, thank you.
You made it. Thank you very much. Thank you.
Thank you.
Ես հույսով որ դուք շատ բաներ սովորեցիք այսօրվա հարցազրույցին եւ մենք մինչեւ մյուս անգամ կհանդիպենք։ Stay tuned ձեզ.
30 seconds. That's how long it'll take you to watch this announcement. What if I told you that in just 30 seconds, you can help someone just like yourself to live again, to love, to play, to laugh? By joining the Armenian Bone Marrow Donor Registry, you're taking a huge step towards saving an Armenian life. Once you're registered, you'll be part of a vast network of donors who have already saved lives all over the world. But we still need your help. Only an Armenian donor can save a fellow Armenian, and it only takes 30 seconds.